Um, Thank you very much. Oops, I think I need my slide. Okay, got it. First, a disclaimer, because it'll be easy to misunderstand. I'm an employee of NIH. I'm the director of clinicaltrials.gov, as you heard, but my comments are my own. They're not official NIH policy by any means. And in particular, since there have been rumors in the past, I want to be very clear. Clinicaltrials.gov does not require patient-level data. We do not accept, I should call it, participant-level data, and there is no future in which we will be accepting participant-level data. So if you hear those rumors, they've been very hard to put out in the past, so let me try to prevent some. Okay, I'm just going to breeze through things that we've basically already know and you've already heard, but it's really important to go back, because the focus of this talk is sort of why are we worried about summary level data, or why isn't that enough, and what have we learned from clinicaltrials.gov. So why do we do clinical trials? This says we have two options, either an evidence-based treatment or an exciting, risky alternative. So this came from my days when people seemed to be really into innovative treatment, whether or not they were good or bad. So you all know evidence-based medicine, and the main point here is the bottom bullet. Most decision makers depend on summary data from journal articles. Okay, the decision makers at FDA are relatively unique in that they routinely have participant level data, but the rest of us, either clinical or policy decision makers, are really left with summary data. So there are three key problems that interfere with the practice of evidence-based medicine. You all know this, not all trials are published. When they're published, they don't always include all the pre-specified outcome measures, which leaves a lot of room for cherry picking. And unacknowledged changes can be made to the protocol that would affect the interpretation of the findings if the reader knew about them. And so example of that is changes to pre-specified outcome measures. All of these contributed to the development of clinicaltrials.gov, which was established in 2000. People register trials at inception, in theory. Registration contains key protocol details. We now have over 130,000 trials listed from around the world. The results database was added in 2008 as a result of federal legislation, and you enter results after the trial is completed. We have summary results, let me emphasize that again, not participant level results, and we now have results for over 7,000 trials, and mostly what I'm talking about is our experience with that. So you saw this earlier when I presented it, but again, just to emphasize that we're talking about the analyzed summary results, but also we've gained insights into how you go from that uncoded data, that first step that Dr. Loader showed some examples of, down to the summary results. So again, decision makers depend on summary results. And why? Well, they're convenient. It's way more convenient. As you know, from my former days as a clinician, it was easier to read a journal article with some summary data than to go through individual participant level data. That would be crazy. And we assume that they're an accurate reflection of the underlying participant level data. And we assume, therefore, that there's little room for subjectivity. I think some holes have already been punched in that this morning, but that's basically the assumption that society, our world, has been working on. So just to emphasize again, levels of transparency, clinicaltrials.gov is over on the left, which is to provide evidence that the trial exists. There didn't used to be evidence that trials existed, and a summary of the protocol details. We don't currently provide access to the full protocol, and then the results database is summary results, and this conference is really talking about some stuff over on the right. Okay. Let's see. So the results database was launched in response to FDAA, the Food and Drug Administration Amendments Act, and it was based on statutory language and informed by consort and other relevant reporting standards. So we were really implementing what Congress told us to implement, and it requires that the sponsors or investigators of trials report what we call the minimum data set. And it's the data set that was stated in the trial protocol. And for our purposes, it's the trial protocol as reflected in the registry record. So you register with some summary data about your protocol, and then we say, okay, you said you were going to measure, give us the mean blood pressure in each arm, give us the mean blood pressure in each arm. It's a tabular format with minimal narrative. And also I should note that EMA, and you'll hear from someone from EMA, I think tomorrow, is developing a results database really based on our model. We're trying to be as harmonious as possible for all obvious reasons. So this is what the tables look like on the left, and basically the 4 scientific modules are participant flow, like a consort diagram, baseline characteristics, your pre-specified outcome measures, and adverse events. All summary data. I haven't said that often enough yet. Okay, we have review criteria. So people enter the data, and we have review criteria. We don't know what's true. We don't know how many people got better in your study. We don't actually even know if you did a study. We have mechanisms in place to hope that we know that you did a study, but we don't know how many people got better. But we do require complete and meaningful entries, so you couldn't enter, a value of 5.4 on the Zarin scale and expect that to stand, because no one knows what the Zarin scale is. You couldn't, we have checks for logic and internal consistencies. For example, the number of participants must be consistent across modules, which doesn't mean that you have to do an intention to treat analysis. We're not the trial police. We don't say what you have to do. We have to say that what you're reporting makes sense. And I'll show you some examples where 300 patients, or participants, showed up. So the participant flow had 400 people, and suddenly you're giving us results for 700, and it's like, great, but who are these people? Time to event must be measured in a unit of time. Things like that. Picky little things like that. 624 years cannot be the mean age. Now, we don't know if 62.4 years was the mean age, but we know this can't be. So that's the kind of review we do. So what were the initial assumptions? We assumed that the required data, so the data that is now basically legally required, were generated routinely after each clinical trial, because again, this is what the protocol says you're going to do. So the requirements are based on the protocol. We assume the data would be necessary to understand the results of any trial, and that therefore the data would be necessary to also to write a journal article. How can you write a journal article without knowing the basic things about your trial? So we thought the burden of reporting would be mainly due to the data entry and the time frame requirements, because there's sort of rigid time frames of when you have to do this. Well, we were wrong. So it turns out what we've learned is that protocols may be vague, may not be followed, and what I didn't write here is, from what we can tell, may not exist. Summary data are not always readily available, even for trials that had already been published. So, we'll have trialists will come and say, well, I published this 2 years ago, what are you hassling me for? And they'll say they don't have the data for their primary outcome measure. Well, we didn't get that analysis done. For many trials, nobody was available who could explain the structure or analysis. And what we learned is there's not an objective, easy-to-describe route from the initial participant-level data to the summary data. Many people and many judgments are involved. So again, going over our minimum requirements, and we still wonder which of these are not used for writing a journal article: the number who started and completed each arm, the age and gender of participants, which are the most elemental baseline characteristics we could come up with, each pre-specified outcome measure, pre-specified by you, the trialist, and adverse events that were collected. If you only collected some kinds, that's all you had to report. We didn't want you to invent adverse events, right? But what we learned is, and this was the most surprising to me, structural changes to study. Arms come and go. People would describe it as a 2-arm study, and suddenly they're reporting a 4-arm study, or more likely, a 4-arm study, and now they're reporting 2 arms of the study. Or arms come flying in from another study. Like, oh, we always meant to include 100 people from this other study. It's like, great, tell us who they were. Participant flow and baseline characteristic tables describe different population than the outcomes table. I never understood that. They'll say, oh, those were different people. It's like, well, why were you telling me their age and gender? I don't really care. I care about the people who are here. Data providers can't explain the denominators. In other words, they'll give us an outcome measure, and I'll say, who were these 59 people? I didn't mean their names. I meant, like, which arms did they come from? And they don't know. So here's an example. This was my sort of Exhibit A that many of you have seen me talk about before. This showed up in a New England Journal article. It's an NIAID-funded study from a few years ago, and it was a 2-arm study, so I do what I do, and I looked up the clinicaltrials.gov entry, and it was registered as a 4-arm study. And then if you read the New England Journal article really carefully, you found out that it in fact said that they were only reporting the people with high viral load, and a DSMB had told them to collapse 2 of the arms. So the New England Journal article had some integrity, but for the purpose of clinicaltrials.gov, you still needed to tell us what happened in all 4 arms, right? So even though the journal article was only talking about half the subjects. It took literally, I think, 9 to 12 months of working closely with the statisticians at the Harvard School of Public Health who were under contract with NIAID to do their analysis to figure out who the people were and where the arms went, where the people went. So literally saying, how many people did you start with and where'd they go, and who is the denominator for each of these outcome measures. And these are brilliant statisticians. They were in charge of the data. And this trial was basically too complicated for them to figure out. So they were giving outcome measures without actually knowing what the denominators were. That's one kind of problem we've seen. We get incoherent entries like, 823.32 mean hours per day of sleep. By the way, I love the number of significant digits. So a lot of precision in the numbers, but like things that make no sense. Time to survive. And these are things that I've had discussions with the principal investigators about. This is not, we had initial problems where people would assign data entry to a clerk or something. But these are times when they bubble up to me. The chief investigators and the statisticians tend to be on the phone. And these are things, time to survival, where the person on the other end of the phone did not understand why that didn't make sense. 36 eyeballs in a study of 14 people. When I said, where'd the extra eyeballs come from, they just sort of said, oh, well, we didn't really count how many people were in the study. Mean time to seizure equals 18 people, so a mismatch between the outcome measure and the... These all give us, they aren't reassuring. As a consumer of the medical literature, these aren't reassuring things because, well, for obvious reasons. Here's an example. This was an industry trial. I have no recollection of which company it was. We were on the phone again. By the time it bubbles up to me, it's gone through many levels. And they had their statisticians from, around the world on the phone, the chief statisticians on this trial, and some investigators or someone else on the phone. And we're going over the adverse event table. And I said, what's the difference between drug and drug all? And they said, well, drug all includes more of the people. And I said, okay, why are the denominators both 297? At which point you heard the statisticians whispering to each other, and then you heard someone say, we'll get back to you. And now look, the percentage of serious adverse events in drug is 51%, and in drug all is 64%. Now you can imagine a situation like a comparator where that's an important difference, which makes you feel like anything could be anything. I actually was going to be brave and have musical snippets in this talk. First was there's something happening here, what it is ain't exactly clear. The one for this was, every hand's a winner and every hand's a loser. This made you feel like any proportion could have been presented, and there was sort of no sense of objectivity here. So examples of changed outcome measures, quality of life scales replaced by a depression scale, 1-month data replaced by 3-month data. Number of people with an event is replaced by time to event, and that's really common. We see a lot of movement between time to event data and event count data. All-cause mortality is replaced by time to relapse. These are just examples. A lot of this is reviewed in this article in the New England Journal, but now I'm going to show you the next thing we've done, which is, so all that work and our experience with quality assurance and the results database is not, like I said, is not reassuring about the validity and reproducibility of the summary statistics. It's very worrisome because you feel like before they had to report to clinicaltrials.gov, they did not have a piece of paper with these obvious stats. And again, this is when their pre-specified outcome measure was mean diastolic blood pressure. And then when we say, tell us the mean diastolic blood pressure, they can't. And that's like, well, what was happening before you had to report to clinicaltrials.gov? So in that context, we worked with a group at Oregon, Mark Helfand, Dan Hartung, and colleagues, on a study comparing when there was a journal article about the same trial and when there was a clinicaltrials.gov entry. And we compared the summary stats, the same summary stats, and not surprisingly, 82% had at least one important discrepancy. And that's not surprising because you feel like there's a sausage factory going on, and the sausage might taste a little different each time you make it. Here's an example, a particularly egregious one, but it was maximal walking distance at 12 weeks under 2 treatment conditions, and in our system it said 618 meters, and in the publication 775, with the same denominator. I mean, as far as we could tell, it was supposed to be the same information. All I can say is they both can't be correct. Whether either of them is correct, who knows? So we have, this is along the horizontal axis is the list I showed from the beginning of types of trial data, going from uncoded all the way to the analyzed summary data. And the vertical axis, in my mind, is level of information. So you're losing information at each step of the way. But also each vertical drop involves subjective and not transparent judgments. We don't know, especially if when we're talking about sharing data, a lot of times people are talking about the analyzable data set. All those judgments have already occurred, and it's very hard to know what they were. And because it's not a straight line, it's hard to imagine it's reproducible, and it's hard to know what to make of the summary data in the literature. So that's our concern. It's a big problem because what you get out of journal articles are a bunch of numerators and denominators. And it's sort of like, what if they're not correct? And if you're doing a formal decision analysis, those are the things that give your point estimates for the probabilities. If you're doing an informal, those are still the things that guide your clinical decision making. So again, the process is not transparent. And just say, this has been mentioned, Dr. Drazen's editorial about that study that I think Liz Loader showed. My concern with this is it's not what's in the data. It's not what you can read in the journal article that worries people. I think it's what you can't see. It's all those vertical drops. And providing more transparency, I believe, might help that. These are the documents that may help to explain the journey. The clinical study report is in there and includes some of the documents from above it. They may help to explain how things were done and may therefore help. So in sum, the journey from initially collected data to summary data is not completely objective. Greater transparency, I believe, could help to inspire trust. And greater transparency could also help the field, meaning all of us who are engaged in clinical research, to engage in internal quality improvements. We have found practices that no one thinks are correct. It's not what's described in textbooks, but previously no one knew what anyone else was doing in their trials. So transparency is what I would encourage, and I'll stop there.